Normal tension glaucoma is a subtype of primary open-angle glaucoma with progressive optic nerve head damage, characteristic visual field defects, progressive RNFL thinning, intraocular pressure less than or equal to 21 millimeters of mercury, and open angles on gonioscopy. So coming to epidemiology, it is more common in Asian populations like Japan and Korea, where 90% of POAG cases may be NTG, and in Caucasian populations 30 to 40%, and in Indian prevalence studies nearly 1/3 of POAG cases. So coming to risk factors, increasing age, female gender, family history of glaucoma, smoking, high body mass index, central corneal thickness, and myopia related biomechanical factors plays important role. So coming to systemic risk factors, abnormal vascular dysregulation like migraine and Raynaud's phenomenon, systemic hypotension, obstructive sleep apnea, and vascular diseases. So if IOP is not elevated, why does optic nerve still sustain damage? So for this, there are various factors like pathophysiology, vascular dysregulation theory, perfusion pressure concept, structural susceptibility, oxidative stress and mitochondrial dysfunction, genetic associations, and multifactorial models. So these patients are often asymptomatic in early stages. They usually present late when visual field loss becomes functionally significant. And coming to optic disc features, focal NRR thinning with notching of inferior or superior neuroretinal rim, disc hemorrhages, peripapillary atrophy, and these disc changes may be disproportionate to measured intraocular pressure. These patients often show localized and deep defects, and common patterns are paracentral scotomas, close to fixation, dense arcade scotomas, and steeper slopes of progression, with central vision may be threatened earlier. Along with systemic associations, which I have already discussed, translaminar pressure difference and also autoimmune disorders also plays a role. So it's very important to take careful history in all suspected cases. So what is the differential diagnosis? Compressive optic neuropathies, ischemic optic neuropathy, optic neuritis, retinal vascular occlusive diseases, and congenital anomalies like tilted disc. So how to differentiate? A detailed neuroimaging in MRI brain and orbit should be performed in atypical cases, and red flags against NTG include younger age less than 40 years, very rapid progression, pallor more than cupping, and neurological symptoms. So we have to take proper history along with the intraocular pressure measurement, gonioscopy, fundus evaluation, OCT for RNFL, perimetry, systemic evaluation, and CNS imaging or neuroophthalmic consultation. Central corneal thickness should be measured as thin corneas can lead to underestimation of intraocular pressure, and OCT angiography may reveal decreased peripapillary vessel density. SWAP and FDT may detect earlier field defects. Blood pressure monitoring, including nocturnal dips with ambulatory blood pressure measurement, and sleep studies for suspected obstructive sleep apnea, and vascular imaging if systemic ischemic disease is suspected should be done. MRI of brain and orbit is indicated in cases with atypical features, and it should always be considered before labeling NTG in young or atypical patients. So these are the landmark clinical trials: collaborative normal tension glaucoma study, collaborative initial glaucoma treatment study, early manifest glaucoma trial, low pressure glaucoma treatment study. Along with them, there are Japanese glaucoma studies, sleep apnea and NTG studies, and ocular perfusion pressure studies. So what is the treatment protocol? First, we have to follow the general principles. Main goal is to preserve the vision and quality of life by slowing or halting disease progression. And because IOP is within the normal range, decision to be made, initial treatment should be based on documented progression or presence of risk factors for future progression. Because treatment is lifelong, it requires multidisciplinary approach considering both ocular and systemic factors. So observation may be considered in early stable NTG without progression, as shown in CNTGS. So based on this collaborative normal tension glaucoma study, lowering intraocular pressure by 30% from baseline significantly reduces the risk of progression. So a practical target should be set between 10 to 12 millimeters of mercury, depending upon the baseline intraocular pressure and severity. If disease progresses despite achieving target intraocular pressure, then further lowering the intraocular pressure should be attempted. So what is the first line management? First line management is medical management. Commonly used drugs are prostaglandin analogs, alpha-2 agonists, beta blockers, and carbonic anhydrase inhibitors. Brimonidine should be preferred because it has neuroprotective effect. Second line options like combination medical therapy and laser trabeculoplasty can be considered, though IOP lowering effect may be modest in normal tension glaucoma. Surgical options include trabeculectomy with antimultiplex, glaucoma drainage devices, and minimally invasive glaucoma surgery. So, role of systemic and lifestyle modifications, like encourage lifestyle modifications like regular exercise, smoking cessation, and good sleep hygiene. A regular follow-up every 3 to 6 months depending upon the disease severity and risk. Monitor IOP at different times of day. If progression is detected, step up treatment even if IOP is at target. Ongoing research like serotonin antagonist, nafdidrofuran, calcium channel blocker nilvadipine, and nimodipine-like agent brovincamines. So future direction, high-dose nicotinamide, vitamin B3, citicoline, coenzyme Q10 with vitamin E, and ginkgo biloba extracts. So 24-hour ambulatory blood pressure monitoring can identify patients who may benefit from antihypertensive timing adjustment at night. So take-home message is, normal tension glaucoma shows that pressure is not the only pressure that matters. Vision loss can occur even when the numbers look normal. Thank you, everyone.
Thank you, Suhasini. We have one more NTG, so we can talk after that.